Okay, thanks, Colin. And thank you, NHS Scotland. I fell off the stage 4 weeks ago when I was presented to 160 Scottish psychiatrists, so I do my best not to repeat that performance. I want to challenge a tyranny of low expectation. I want to leave you with an optimistic message, and I think and a really important message about we need to do this early. It's about time. It's about time this was taken as a serious issue, but I think also the opportunity is about what happens in the really early phase of illness. I'm going to challenge the idea that you can split bodies and minds. As a GP, it never made any great sense, and yet, we run different silos. So it's about time. Just some declarations of interest, but in a sense, that the thing about complaining, I have been a jobbing GP. I retired some years ago, and I got involved in a process of complaint at what shocked me about the sort of care that was given to my 16-year-old daughter, and the fact that when I complained as a health practitioner and was, in a sense, told off for complaining, I thought, well, what chance has the someone who hasn't got experience of health services? So I felt that was outrageous. So I became an over-involved dad. When I retired 4 years ago for the early intervention program, my wife was actually quite worried that I would not have enough to do. So it's actually very. Thank you for inviting me here. She's delighted to have me out of the way. So Mary went into an 8-bedded dormitory without curtains and carpets to receive rehabilitation at the age of about 19. Okay, having had a fairly difficult time. Tried lots of different medicines, and I think the scariest thing for me as a dad was this low expectation. I've called it the message of despair, psychosis, the message of despair, because actually everything I saw inside that service, not that the staff were not trying to do a bad job, but they were in a very pervasively pessimistic environment. So there were groups of elderly men in the 60s and 70s who were smoking. Mary started on clozapine, and clozapine actually changed her life. It was the one antipsychotic medicine that transformed how she viewed life, the terror that she was experiencing at the time. However, the environment she was in, the clozapine also gave her a raging appetite. The staff felt sorry for her, so she got extra helpings of puddings. She sat around, she did nothing. And the one thing you could guarantee Mary would do was take her medicines. She's a very compliant person. So this was the environment, and she was clearly on a different destiny. So two different destinies here. To her two brothers, they didn't have psychosis, they didn't have antipsychotic medicines, they had an environment of hope, and Mary didn't have that. So we were, right at that very beginning, I was conscious of this huge difference in destiny. This, in a sense, this graph talks to me in two different ways. It talks to me personally, because the sort of weight gain you see here is exactly what we witnessed in Mary. She went from 9 stone to 13.5 stone over the space of a few years. This is a systematic reappraisal of evidence. Much of this evidence was gathered by pharma industry-sponsored trials, and they tended to be short-term trials comparing one drug with another drug, and they very much look. A lot of the evidence has come from people with established conditions given antipsychotics who had previously had treatments. They were already overweight. If you look very carefully at these trials, which is what this study does, what you discover is that people taking antipsychotics for the first time gain, on average, 12 kilograms in the first 2 years. And then it sort of slows down. But that first experience of weight gain is exactly what we saw as a family. Mary started her treatment at about the time the second-generation antipsychotics were introduced. And yet now we look back and think, well, maybe this was a marketing ploy. There aren't such clear differences between the first generation and second generation drugs. So there are some very serious questions, I think, about the drugs that are used in the treatment of psychosis. And just picking that issue up again, this is a recent publication from a very impressive group in the States led by Christoph Carell. And they were asking the question, in terms of the metabolic risk, and understanding that, for people like Mary starting her treatment, the metabolic risk, if you use a concept of metabolic syndrome, is pretty similar to the general population. It's effectively the same, but within 7 weeks of diagnosis and taking treatments, antipsychotic medicines generally, this population have So there's just 7 weeks. Obesity levels of over half are showing abnormal lipids. The rate of metabolic syndrome has doubled within 7 weeks. So the message here is this goes up very, very quickly indeed. And interestingly also, about 50% of this population are already smoking. And if you look at the smoking rates of this population, they're 5 or 6 times higher than their peers. And that goes back several years before the diagnosis of mental illness. So there's some very serious issues about smoking. And that's the single biggest contributor to premature death. So and in a sense, you can argue about what exactly has caused this. Is it due to the drugs? Is it due to the environment? Is it due to the illness? The one thing we do know is that this is the reality within weeks of starting treatment. This is a qualitative review led by the late Helen Lester. I'll just read out the quote, and I think it really, echoes what Graham described. And as a GP, I stand telling people what to do. It's my hobby. And I would question whether this young population actually engage with me when I'm saying this is going to shorten your life. But I think the issues are sort of summed up in this. I see quite a lot of people I used to know, but because I've put on a bit of weight and I look a bit different, they don't recognize me. I would have said, hey, it's me, but now I'm glad they don't recognize me anymore. I wouldn't know what to say. I think it's a self-image. I think it's how you feel about yourself. The fact you can't run for a bus. The fact you can't get into the clothes you wore a few weeks ago. And so for people like Mary, now Mary's 38, and this is a typical age of the study from the national audit. So people who've been ill for 10 to 15 years typically. So Mary has a rate of metabolic syndrome 3 or 4 times higher now than her brothers. There's a study from Belgium which showed that at this age, they screened a population of people with the same sort of conditions, the same length of illness and treatments, and they found that 10% of that population, previously unknown to have diabetes, had actually got diabetes. A third of the population were at high risk of developing diabetes. So biochemically shifting, there are things we can do about that. So this is, again, emphasizing this trajectory and pathway to premature illness and death. One of the very strong figures in my training, Julian Tudor-Hart from the Welsh Valleys, saying that this notion that this population get an inverse level of care for the level of care that they actually need, that their health needs require. So the national audit, again, is a clear emphasis that this population with high risks of having premature heart disease and diabetes have woefully low levels of recording. I offered my daughter-in-law as a practice nurse. I got retired. I offered her a training with her colleagues, practice nurses. 25 nurses were happy to give up time to have a half day with an LGP. The practice managers blocked it because it wasn't core business. They wouldn't release their nurses to do something they didn't see as core business. That drove me. That really did drive me. I felt ashamed about what that said to me. So in a sense, that's the bad news. Positively, for the very first time in a very big early psychosis conference, Helen Lester and I ran a physical health symposium. That in itself was quite unique. And at the end of it, we said, if anyone wants a cup of tea, we're in that table over there, and 6 people wandered over with a similar interest. So we set up a sort of special interest group, but there were only 8 of us. One of those people was Jackie Curtis from Sydney, and she came waving a sort of 2 sides of A4. And Helen and I, being GPs with very short attention spans, our eyes sparkled. You think, this is exactly what we need from primary care. A clear, simple definition of what are the things we should be concerned about, what are the numbers, when are people in the red, how do we help people to get into the green. A very simple framework. And it didn't matter whether I was a nurse or a doctor in primary care or secondary care. So we took that back. I went back to the national audit team, and they said, David, your job is to nick this from Australia. So Helen and I spent a lovely 2 years, very precious 2 years, because Helen died towards the end of that phase, nicking this resource. And we called it the Lester in respect of Helen's contribution. And the other thing we got involved with was this notion of healthy, active lives as a statement of rights, but I'll come back to that. So we established this idea of having a framework for concern. But the really important thing here is that slogan at the top on the right. Don't actually doesn't show, but don't just screen, intervene. That's the point. You know, as a GP, I can monitor people to death, but if I take no action or concern about what I'm finding, then it means nothing. So this message about don't just screen, intervene, I think is a slogan we should use in our campaign, actually. That's what we should be saying. So what does that mean? Smoking cessation is probably the single biggest determinant of health inequality and premature death. A recent study from Simon Gilbody's group in York have shown that actually encouraging community psychiatric nurses in the main to walk people through access to smoking cessation services increases the likelihood of smoking cessation, doubles it within a year. It's a small study sufficient to generate a major RCT which starts this April. So, but in a sense, we sort of know the possibility here, but this is important work, so watch this space. But I think what we'll see is facilitating this group of people to raise their expectations and to access some practical services will make a big difference. Metformin, cheap as chips. There is now interest in whether metformin can be given very early in the course of the sort of weight gain I've just shown you, whether that may attenuate or mitigate some of the weight gain. It's another pill, that's the disadvantage. But again, the possibility is sort of exciting people. But in people who are at high risk of developing diabetes, metformin is an extremely effective way of delaying the onset of diabetes. Now, you're talking as a father, Mary's illness is a tough illness. She has a lot of impairments. The thought of her having diabetes as well as a psychotic illness is very scary as a family. So even delay of something is well worth having. So metformin, it's been around for years. It's clear indication in our NICE guideline that this should be used in people who are at high risk of developing diabetes. Prescribing. In the national audit, there was a wide variance of prescribing performance. So about 10% are having doses outside the national formulary recommendations or having polypharmacy, and yet the evidence for that is really poor. So there's clear issues about prescribing. And just finally, just gone to the time, I just want to focus on a couple of things, the nutrition and physical activity. Now, you know, the sort of things I can almost remember hearing was, we'll sort out the symptoms first, then we'll deal with these sorts of issues later. And I want to just try and challenge that. And this is just an indication of just what's possible if we go for this. So the message here is an ounce of prevention is worth a pound of cure. This is what happens to the general population. If you can effect a 10% shift in body weight, then what your prize is a quarter less premature mortality, a half less type 2 diabetes, and it helps reduce your cholesterol and improve your blood pressure. Okay, so that's what happens for the general population. You get the best bang for your bucks if you prevent the weight going up rather than bring it down. But I'll settle for either. Okay, so that's the potential here. This is an editorial from the States recently. There are a number of studies now coming out in the States. I'll pick out the things in red that clearly demonstrate that clinically significant reduction in cardiovascular risk is possible for approximately 50% of overweight and obese people with severe mental illness. That behavioural interventions for obesity in people with serious mental illness should be considered an evidence-based practice. This is no longer a knowledge gap, it's an implementation gap. Okay? And just finally, I just wanted to, this looks a bit of a complex slide, but there's a very simple message here. So Jackie Curtis, who we nicked the resource from, has also been a part of an early intervention programme, has had an ethos of body and mind for several years. And that's manifest in them being able to number crunch what happens when an exercise physiologist and a nutritionist working in the early intervention service gives support to the young population going through a service. Now, if you look at the red bit, the New South Wales standard care, that's what happens in an early intervention service without Scott or Simon in it. And I'll just pick the weight as just an illustration, but 7.8 kilograms weight gain in 3 months. Okay, a small number of people, but that's typical of what happens. That isn't. It sounds unbelievable, but that's typical of what happens. In Jackie's service, the Bondi service, 1.8 kilograms average weight. So a reduction of weight gain at 3 months, 5-fold less. In a population, you saw the trajectory, but it's Bondi. You'd argue, well, of course, you know, surfing capital of the world. But my mate Joe Smith, who I was a job sharer on the early intervention programme in England, Joe's developed a collaborative programme with Worcestershire University's Health and Wellbeing Programme, so a collaboration with a public health approach. And the youngsters going through Joe's service also have protected access to an enthused and energetic health and wellbeing service. And basically the message is Joe's service is matching the Bondi service. So that this is ongoing NHS improvement funded work, and it's an example of what can be done. Okay, these are exemplar services, but they show the possibility. So I just want to conclude really. I think the opportunity here is early on. That's what I'm trying to say in all of this. There are very practical strategies that we can begin to do. Sure, we need more research, but I think we're beyond the need of just researching. I think there's time to implement here. So the message is start really early. It isn't sufficient just to monitor. So much as I would love to see, the Leicester algorithm as absolutely part of general and secondary care practice, just monitoring is not sufficient. We have to be concerned about what changes. And really just to finish with this is a notion of social justice. This was a group of service users and families, an international group, high-level researchers within that. And what we're talking about is that I shouldn't lose health. When I receive a diagnosis of a major mental illness and its treatments, I shouldn't expect to lose physical health. I should expect it to be protected. And so we've set 5 standards, 5 high-level outcomes. They're in your pack, so I encourage you to have a look at particularly these 5-year targets. And aspirational they may be, but what Joe's service in Worcester and Jackie's service are demonstrating is not just aspirational. So we expect that people shouldn't gain more than 7% body weight in the first couple of years, that their biochemical values should stay within the normal range, and they should get access to the sort of health-promoting approaches that we are beginning to see evidence-based for. And I think that's probably, I just wanted to acknowledge, I guess these slides may come to you if you're able to access them, but one person in particular I'd want to acknowledge is the late Helen Lester. There's a YouTube clip which I'd really urge you to read, which Helen gave just a few months before her death to the great and the good of the College of General Practitioners, the James Mackenzie lecture. And essentially Helen talks about the very simple things that we could introduce tomorrow to try and reduce the actual discrimination that takes place in my business, in primary care. To acknowledge the Australians, I think the official one is good on you, Cobber. And finally, just to say, I wanted to finish really with a thing about this message of hope. Mary was definitely written off in terms of the system. This is the family wedding in Cumlongan in Dumfriesshire. 5 or 6 years ago, and Mary's doing okay, and she loves walking, she loves dancing, she particularly likes shopping. She has a lot of impairments, but she's very much part of a family. So the message here is about family. It's also a message about hope, that if you write, Mary, as I say, was written off, and writing off people's bodies as well as their minds is something that we should think very carefully about. That's such an important message, I think, for staff. And the final thing here is that I don't know, we have a family history of mental illness when I look back at the generations, and I don't know what's going to happen to the next generations of Shiers family. I would hate to think I just sat back quietly. That's partly why I'm not retired. I wouldn't like to just sit back quietly. Knowing what I now know, and my reflection on this 20 years, is that the beginning of this is such a critical opportunity for change. So thank you very much.